Hi, everyone. I'm Samira, the host of the podcast, The Patient from Hell. Thank you so much for listening in for the last many months. Today, I am truly thrilled to have the guest we have on. I can tell you already that although we're supposed to be recording one episode, the odds are you're going to listen to us a few times on a few different topics. So with that, I'm just going to go right into it and tell you how I got to know our guest today and then have her introduce herself. So I got to meet Dr. Kogan while I was a patient as well. As I know you guys know, I'm a breast cancer survivor. I was going through radiation therapy when my rad-onc looked at me and she's like, "Are you getting support for mental health?" And I was. I had a therapist and I was seeing him every week. And the rad-onc looked at me. She's like, I really think you still need to go meet Dr. Kogan. I just think you guys will get along and she'll be able to help you because she's a specialist in the sympathetic and parasympathetic systems. So that was how I got to meet Dr. Kogan first. Then I realized that she has this whole other life outside of seeing patients. And today we have her here sharing much broader views on what she does, how she helps patients, and then her new life as an author. So, Dr. Kogan, welcome to our show.
Thank you very much, Samira. Yeah, thank you for inviting me and sharing this work. I appreciate that. And yeah, as you mentioned, we met in a professional capacity. And so I'm an integrative medicine internist, and in private practice also a clinical professor at Stanford. And one of my expertise is cancer distress. It's distress in general, and that's why you mentioned, parasympathetic and sympathetic. What happens to us when the autonomic nervous system gets kind of, runs wild, haywire, and really messes with our thinking, with our experience, with our decision making, with our emotions, with our, physical experience. And as a cancer patient, that is, at the forefront of this very stressful sequence of events, from hearing horrible news, having to make very difficult decisions, having to endure sequence of treatments and side effects, and then either living with illness is incredibly stressful, or the fear of illness returning even if it's gone. And so cancer is kind of at the center of an extremely stressful experience. And that can, get misinterpreted as kind of a psychiatric problem. And I really want to help people to learn differentiate that. Like when you feel like, oh, I'm going crazy, that might just be a manifestation of your nervous system messing with your brain.
Dr. Kogan, there were so many things you just mentioned that we can dive into, but before we do that, can we actually start with what happened just before we hit record? So we were I think it started by me communicating that we were recording not just audio but video as well. I'd love for you to share your reaction to that and kind of what happened.
Well, I was immediately self-conscious because, from our communication before, you said make yourself comfortable and wear clothes that are comfortable, and I'm like, okay, that sounds I can do my pandemic self where I'm just heard and not seen. And so when you then said, like, this is how I'm going to look, I became very self-conscious. Like I hadn't done my hair, and I hadn't, I wore the wrong glasses, and also, this is my dad's sweater, and he recently passed away, and to surround myself with a little comfort zone as I step into this public space, it's personal. And then, the color of my glasses wasn't matched up, and so it became a whole I don't know, self-conscious performance moment. But then, we explored it, and you made me comfortable and said you can do whatever you want, and we even tried with more professional clothes, and they were very uncomfortable. So I'm back in my pandemic self.
The reason I wanted you to share that was I know I relate. I think the social anxiety post-pandemic has been real. I think the social anxiety post-treatment and the pandemic has been very, very real. And I have a sneaky suspicion that a lot of our listeners have similar moments.
I mean, you also now have to put up with my son's gaming chair.
Oh, I didn't know that.
So it's the most comfortable chair. I went for comfort, and now.
Mm-hmm.
But so let's hope we translate that into the comfort of the audience and people who share this space with us now.
Thank you for sharing that you're wearing your dad's sweater. I think that's the other piece that I think our audience can relate to. I know that our audience has lost people to different things, and that process of grieving, that process of unpacking, that kind of life moment, I think is difficult for a lot of people. And there was something you said initially just before we started recording, which was the mind-body connection.
Mm-hmm.
If you're up for it, maybe we can start there. How have you personally grappled with kind of life? How have you used the kind of tools that you talked about in your work to sort of help yourself?
Yeah, I think that was a gradual kind of expansion of knowledge and experience. As a physician, you're trained very analytically. You think through everything, and so it's very thought dominant. And I came to realize that certain experiences don't really have much cognition or explanation or words to them. It's a very experiential space that many people also can't relate to. And I started getting to know my own thinking. I mean, I briefly mentioned it before we started. So, like, doing this podcast is like really trying to convey the work, but from an experiential experience, not just from, oh, look, do this and then you'll feel better, but really, what does it mean to have feelings that are challenging, or, being self-conscious about the thoughts, am I doing okay today, or, am I coming across as intelligent, or, these very self-conscious experiences we have, and to really look at them and put them in the perspective of what matters to me, like the essential in a cancer experience or in a loss. What is that to us individually? And for me, it had a lot to do with integrity, to not give up on my values. And that's something I discuss with many of my patients. I've got to think of an example. If you, during therapy, during chemo, don't want to do something someone else recommends, why don't you go for a walk? It'll be good for you. And you don't want to go for a walk, can you allow yourself, or you can't go for a walk because you're too weak or too nauseous? Can you then go inward and say, okay, like, this person means well, but I can feel that this is not the right thing. It's an awareness expansion of ourselves. How to connect with ourselves, and then also how to connect with others. If I don't know myself and how I operate, then I will fail in my relationship with me, and I will fail in my relationship with others. But I'm not sure that addresses your mind-body question. No, it does. The mind is this production of, escalating thoughts of various, inclinations, but then the physical experience or the emotional experience that is attached to those thoughts. And I try to, integrate them. When I have a physical sensation, I don't know, when my heart beats faster, then I wonder, oh, did anything just happen outside of my awareness that might have activated me? And then, I check for my thinking. Was there any thought content that happened outside of my awareness that I have to kind of retrieve and say, oh yeah, this moment was unpleasant. That's actually something I want people with an illness, not just cancer, to do, is be present for their experience. If I now tell you, go for a walk, Samira, your mind might say, oh, that's a brilliant idea. But then your body says, no, thank you, I'm staying in bed today. I can't get up. And so you need to bridge this disconnect of what your body can and wants to do and your mind that's battering it often.
So where do you start? Do you start with the physical or the thought?
For me at this point, it's really both. Most people start with thought, but they're not aware of their thoughts. So in the exercises that I do with people is to just a simple awareness exercise. What are you thinking right now? What are you feeling right now? Do you have an emotion that's attached to it? And there's any body sensation that goes along. And then it's like a puzzle that you can put together. So there's not real, the starting point is really what's most prominent, like that can be a feeling, that can be a thought. In many people, it's strong, physical sensations like pain or fear. Fear is kind of this blended experience of, a very physical chest pressure or sweating or palpitations. And the thought is like, oh my goodness, the cancer might come back. Or like, oh my goodness, I can't do another round of chemo. Or my goodness, how do I get this neighbor out of my house? Or, it can be a lot of, there's no, I would say what's most prominent at any given moment is what I go after, and then I just put the pieces together. Yeah.
And from what I understand, anyone in any sort of situation can technically use that tool, right? They can use.
It's not cancer related at all. Anybody with any kind of stressor in their lives. It can be an illness. It can be a loss. It can be a job loss. It doesn't have to be the loss of a person. The more existential it gets and potentially, is killing you like cancer, then it gets particularly scary. With a job loss, you can say, okay, we'll find another job. But there are many people in our society for whom that's not true. They lose their job and they cannot find another one. So many of the things that we're talking about today basically applies for any external stimulation that gets our system going into fear and worry and fear of death ultimately also in the space of cancer.
Can we actually maybe go back to something we opened the episode with, which is like a couple of definitions. So we've thrown out sympathetic system, parasympathetic system, autonomic nervous system. Would you mind just like defining it for our listeners?
Yeah, so I just want you to think of like, different organs. There's a brain, there's a heart, there's a lung, we're made of, you can look at a picture online or in a book, how we look on the inside. And people are used to, the nervous system in the context of muscles. They can imagine, they can relate to, my brain tells me to move my arm. There's a nerve that connects that function to the muscle, so that's a nervous system that's under our control for the most part. And the autonomic nervous system does the same thing, but mostly outside of our awareness, connecting the brain to every organ that's inside of us, like the heart, like the lung, like the gut, like the liver. And, it is autonomic because many functions, like beating a heart, I can tell my arm to move or not move, but I can't tell my heart to beat or not beat, or I can't tell my liver to stop producing, cholesterol. That's why the word autonomic, it happens on its own. And people are not, now more and more people have heard the term fight and flight and freeze. When I started this work, many years ago, that was not something people were familiar with. Autonomic nervous system was not part of their vocabulary. Fight, flight, freeze was not part of their vocabulary. Even though, there was plenty of research that was done at the time and people working in that field. But now it's become common knowledge to use the term fight and flight and freeze. But I'm not sure people are aware that when that system is activated, how it affects their brain, for example. If your heart beats faster, that's an autonomic function. But I don't know if the heart beats faster because, whatever, I might be having a heart attack, or the heart beats faster because I had a thought that's quite stressful, and the heart, through the autonomic nervous system, responds to that thought. There's a direct connection between the body and the brain. And so in many ways, I educate or help people connect to that system as much as they connect to, how to move an arm. We can also learn how to treat a heart and a lung well.
And how does that relate to the sympathetic and parasympathetic system?
Yeah, that's a subsystem. Thanks for, I tend to, when I get excited about something, I just go on and on and on. And so I just gotta, thanks for reining me back in. I'll try to be a little less blabbery. That's just a subset of activation, fight, flight, freeze. It activates the heart. That's the sympathetic. And then what slows everything down, some people also call it, I think, rest and digest. Slowing down the heart, sleeping is in that category. We need the parasympathetic tone. Think of it as a squid coming out of the brain, long, tentacles, and those tentacles need to be balanced. So it's activating and deactivating. And most people in our kind of particularly Bay Area oriented society are chronically activated. They don't even notice it. They don't sleep well. They have headaches. Their digestion doesn't work. And they're not aware that they're chronically activated.
So is it fair to say that a large part of your work is teaching people to deactivate their chronically activated system?
I think that's a fair statement. Yes. And then also, I might add one thing without talking to.
Of course. You're not talking too long.
To separate external stimulation from internal stimulation. When people talk about fight, flight, and freeze, if I put a gun to your head, of course you got to be activated and you got to fight back or run. But people aren't fully aware that their internal system activates them. Someone with fear, if their heart beats faster, they might say, oh my goodness, do I have a heart attack? Or someone with pain, that's an internal signal. It's not an external signal. It's an internal signal. Might say, oh, my cancer is back. So that's a very activating thought. So I make people aware of the differentiation. Also, is that activation external or internal?
That actually is amazing. Can we use an archetype? Because in our sort of broad global community, we have patients who are newly diagnosed, we have patients in active treatment, we have survivors, we have caregivers.
Mhm.
And I'd imagine that the external and internal stimuli for each of these sort of very, very broad populations can be very different. So if you're okay with it, maybe let's start with survivors. For a couple of reasons, I've heard you say a few times the concept of fear of recurrence, cancer's going to come back. I'm imagining that fear is a thread, trauma is a thread. There may be a couple of threads in that population. So maybe we just start there and use
Yeah,
that kind of as a
I mean,
algebraic approach.
I think you just, said you beautifully into different stages, and I want to add, unless I missed what you just said, living with the illness, that's also a
Yes.
stimulator. So the word cancer is such a big umbrella, and that's like saying I own a, means of transportation. Do I have a tricycle or a Lamborghini in my car, in my garage? So, using the word cancer are so many different illnesses. And, it can be a little mole on your cheek to you're close to, leaving this world behind. And so when it comes to survivorship, and again, I think it applies actually to all of them, even at the time of diagnosis, is the concept of uncertainty. I don't know what's going to happen in the future. That's a thought that's unbearable. If we talk about internal stimulation, like, oh, the cancer might come back, that's a true statement. But you don't know whether or not it comes back. It might or it might not. And, people always want certainty. They say, oh, I've met my 5-year mark. At this point, I have whatever, 2% chance of recurrence. But if that means 2 out of 100 people, yeah, that's wonderful for 98. But if you are 2 out of the 100, and you're the one who, after 5 years, gets a recurrence, then you're still confronted, with a very stressful scenario. And so survivorship is full of that. How do I manage not knowing? Good odds, bad odds. Some breast cancer survivor have excellent odds. We're not supposed to use the word cure, but you can. If you have a minuscule chance of recurrence, I wouldn't want that to affect your life. So I think that's an important theme, but uncertainty and unpredictability. It's like, how do I manage my life if I don't know? And that's a very individual approach. Am I now going out and live life as, it's coming to an end tomorrow? Or do I live life as if I'm going to live another 40 or 50 years? That's a very different approach to life. And in some ways, you got to do both. And how do you do that? How do you live as if life is going to be shorter and with more awareness? Or how do you live, with life lasting? The different values become important depending on the scenario. You got to juggle them both. And that's very stressful.
So I'm going to ask you maybe a slightly cheeky question, but really, how do you do that? And I ask as a survivor of breast cancer, and I've definitely grappled with both, and it's really hard. It's really hard. Like, yeah, in my case, the odds are good. Like, I have really good odds, but I can tell you from, and I know you know this about me, but I love data. I like looking at the odds. I like doing the math and understanding the probabilities. To get a diagnosis of breast cancer at 30, that is very low odds. Very, very, very low odds. And once I've become that outlier, oh man, it's really hard to look at probabilities with a rational head anymore. Because I've already been in the kind of edge case, right? So how do you as a survivor figure out what your values are?
You illustrate the point of the low probability. And, I want to inspire, and I want to use that for myself also. How do we learn to live with uncertainty and live a good life? So I often hear people who went through a statistically, low probable scenario, like a 1% chance of something. Say, they're just waiting for the next shoe to drop, even though the scenario is still low. And, going back to something we talked earlier, this is now important in terms of internal versus external stimulation. Even let's say the odds are 50%, when they talk about median survival,
Sure.
let's say it's 5 years. That means 50% of people live longer than 5 years, and 50% of people live less long. But you have no idea if you are, as an individual, as an N of 1, above that number or below. You don't know. So, how do we learn to live with I don't know? How does it affect your day today that you don't know how long you're going to live? Does that change your day, how you live it? Most of us don't enter that space. We do our work and we go shopping and we don't think about these existential things, but you have lost that luxury. You will think about it. And so the internal stimulation then becomes the thought, oh my goodness, I might not live. And then that's a very stressful activating. And there I want to teach people to look at that thought. Is that thought helpful? Does that thought make you more aware of how you live? Or do you want to think something else instead for just today to help your body? There is no external stimulation in terms of putting a gun to your head. It's odds, and we don't know how they're going to play into your life.
Yeah.
But the thought will enter your brain. What do you do with that thought? Because it will stimulate your body. It will evoke fear. I mean, in most people. I mean, you can speak to that as a,
Yes, I can. I'm getting chills right now because I think it's extremely real. I for the last how many years now, I don't think this is public knowledge. I don't think I've ever said this actually. I mean, publicly. I started a practice, I want to say during infusion. This is 2021. I started this practice where I, every single day, would wake up and ask myself, if I only get to live today, what would I do? And I wrote it down. And I wrote it on the back of my calendar. It's actually, I'm sitting at my desk, and after a year of doing it, I have them all framed. Because I did a year of that, did it again last year, and then I do it every day, and I can show you. Like, I have a calendar, and on the back of my calendar, that was the month of January, was what I did every single day, to the question of, if you only get today, what would you do? And I think for the most part, I think I've taken something that terrified the crap out of me the first year and made it something that is, generally speaking, pretty positive. Like, things on here are like pretty small. Good cup of coffee, good walk. They're not the big things. So I definitely think my daily life's gotten better. But it makes planning annually, 2 years out, 3 years out, 5 years out, really, really hard.
Yeah, but
that's really hard.
And there, let's talk about that, because I want to encourage you to do that both. And I'm glad you're so courageous to share that practice publicly, because I have the same practice, but I wouldn't have dared to share it publicly because people think it's very morbid. When I tell people I do that, it's like, what? And so, that morbidity level, but I do the same thing, and it makes me a better person. You said it's maybe a walk, or sometimes it's not that big of a deal, and you don't do very drastic things. And it definitely makes me a better person, it makes me kinder, makes me less reactive, it makes me less projective, and often I fail, I must add, but at least
Same here.
At least I sharpen that awareness. But I do want to encourage, and I I sometimes do that exercise with people. If I had to live, and I actually don't do the 1 day part. I do a year. If I had, because it is very scary when you're in the middle of treatment or in survivorship or live with illness. To say someone, well, what would you do today if you die tomorrow? For someone with metastatic illness, that is scary, and so they might not want to do that exercise. But for people in survivorship, to say, okay, if I lived 1 year, 5 years, and 20 years, would I go shopping today? And so, is the answer yes or no to whatever? If I live 1, 5, 20 years, what would I do with my 401k if I have one? And so, unless the answer changes, it doesn't matter what you do. If the answer is the same, I still go shopping, then go shopping. And only look at the things that matter. When you say it's hard to plan, 2, 3 years out, I hear you. But don't spend your 401k quite yet. So you need to, live as if you're going to live another 50 years, maybe with some modifications.
I'm laughing partly because I think
you have spent it, or you've spent it already.
No. But my spending habits have changed. I will tell you that. They have definitely changed. But no, I've not spent my 401k. But I definitely did that exercise. I think I do it actually annually every year.
Mm-hmm.
And I think for me the time periods are 1, 2, 5, 10. And I think you're right. My answer didn't change. Like the 1 to 10 year, it's actually been pretty consistent. And I think that gave me a lot of reassurance that I was living the life that I wanted to live.
Mm-hmm.
So I've tried to do that. I don't think that's gotten rid of the internal stimuli though. Right. So there's the I have my daily practice, I have my annual reflection.
Mm-hmm.
And then, oh man, this is so recent. We're recording in February, so a little bit out of when it's going to get published. But I just went through my scans, and everything's fine. Knock on wood, life's good. But oh my god, the last 2 weeks were stressful.
Mm-hmm.
It's all of a sudden, it's planning is just gone. It's I cannot plan. It's planning is out the door. It does not exist.
Yeah, and so can we use this as an illustration for external and internal stimulation? So the external stimulation, there is a scan on the schedule. That's an event and it will happen. The internal stimulation is what's going to be on it? That's a thought. And that's hard to balance. Ideally, Robert Sapolsky wrote a lovely book. It's called Why Zebras Don't Get Ulcers. Humans can't just go to the scan like a zebra would. And then if there's something on the scan, we deal with when there's something on it. The mind, the cognitive part of our brain, just in humans doesn't work that way. But I am working with patients on being zebras in that moment. What's our best zebra rendition when you do have to go to the scan? And what's the best way to rein in that thinking? There's something that's called defensive pessimism, that people who, anticipate the worst won't be as surprised when the bad outcome happens. But those studies, I think, were done on people who took the bar exam, lawyers who took the bar exam, and not on cancer survivors. And it's true, if you anticipate the worst and then you pass the exam, you're excited, and you already made a backup plan if you didn't pass it. And so, but living with, do I have to go through cancer treatment again? Just that thought for a lot of people is unbearable. And you mentioned, trauma. It's traumatic to not just be diagnosed, but the treatment itself is painful. Yeah, can save your life, but there's a cost-benefit analysis, and the cost is fear and pain, and you know that better than anybody.
No, it's definitely true. If you're okay with it, I would love to go to this one of the other archetypes because we've mentioned it a few times, which is living with cancer.
Mm-hmm.
Right. So the group that is actively, essentially going to be forever in treatment.
Mm-hmm.
I would love for us to talk about that because I think there's one of the themes that we've been unpacking on top of internal, external stimuli is
Mm-hmm.
a theme in your book, which is the
Mm-hmm.
quantity and quality of life.
Mm-hmm.
And how you grapple with that. And I would love for us to talk about that if you're okay with that.
Yeah. I mean, we mentioned that the word cancer is this big umbrella, for a precancerous lesion on your cheek to living with an illness that then is also has subsets of people of living shorter or living longer. You can live with cancer. There are some cancers you can live with for literally decades. But you don't know. Once you enter the space and the word metastatic is spoken, talk about stress. That is hard to wrap your head around, particularly when you then, you're confronted with positive affirmation and people say, "Oh, think positive," and and you'll beat it, and there's a lot of rallying around a person that can be helpful, and the intention is well meant, but it doesn't quite match or meet the experience of that person who all of a sudden, and that's I call the book When Cancer Visits, for that reason. Cancer becomes part of us and sometimes doesn't leave. A visitor usually leaves, but some unwelcome house guests move in. And what do you do with that? Particularly if you're compared with people who are cured or have versions that are most likely not deadly. And then to differentiate, do I live 1 year or do I live 20 years? I now have something in me that has an incredibly low probability of leaving. That's stressful. And in that space, quantity versus quality is a constant negotiation. I mean, I talk with patients all the time. It's like, do I do this treatment because, I have diarrhea with it? And when I have diarrhea, then I can't eat enough. And if I don't eat enough, I'm too weak. And if I'm too weak, I can't go for a walk. And then that will shorten my lifespan. That's a mental cognitive head spin that's very stressful. You're caught, between all these choices and this optimization of very difficult choices. And there's never a good answer. There's only a cost-benefit analysis. Okay, the cost in taking the medicine is that high, the benefit is this, but if I look at the cost, it's attached to another cost. So it's this complicated decision-making algorithm that's overwhelming. And then the question arises, if I want quality and it comes at the price of quantity, do I have the right? Of course, legally you have the right to make that choice, but your loved ones won't like it because they will always go for quantity. I lost a brother to cancer, and for him it was very, 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 very clear that, at one point, and going to get emotional about this, that his quality of life, was not to be touched. And he had to make a choice at one point where, his tumor wrapped around the spine and he was basically paralyzed and they couldn't operate anymore. That he could have lived for a while, weeks, maybe months, in a wheelchair. And we were like, "Oh, that's cool. Like, we'll push you around and, well, don't worry about it. Life in a wheelchair. At least we have you. We wanted the quantity. And he says, no way, I do not want to end my life in a wheelchair. And so, at that point, he, there was no further treatment, and he died very, very quickly afterwards. It's almost, it's hard to talk about because it's, once he decided that was not a life worth living, he went out the door rather quickly. And so that left a mark in me, like this experience. I do not get the quality wanting to live. So then, I don't want to say we can will ourselves to die, but I've seen it before, that when people don't have the will to live, that it changes them, and it's hard for the people who have to accept that. That's a mutually competing need. I, want quality as a patient, and my loved ones want quantity. They want me to be around. Very, very, very difficult. Very, very, very stressful for everybody involved. How do you choose that? Who gets to choose and be at peace with it?
So that was so we recently launched our community in India.
Mm-hmm.
And this was fairly recent, and we are a global community. We've always been global from the get-go, but in India we just don't have there just isn't as much of an infrastructure on and any of the stuff that I think in the US we largely take for granted. And there are a lot of cases in India where early detection is not as common. Therefore, most of the diagnoses tend to be more advanced stages, and there are a lot of people who are living with illness, and the dynamic between the caregiver and the patient is very different.
Mm-hmm.
Where I think what you spoke about in terms of quantity and quality, the competing interests, the competing goals, I think that definitely applies here. In India, I think it's a little bit more complicated because there, the family member or the loved one is largely the one making the call, as opposed to the patient. The patient's not always, is not given the agency, I think, in the same way that you might be here. And I'm just curious from your lens, what you've seen, because I know you see people across cultures and across kind of geographies as well. And I'm curious how you've seen that kind of play out.
Yeah, I mean, we've actually, working on this cultural expansion. I mean, it's, again, I mean, that we can fill a whole podcast just with that question. If I start on an individual level, it's hard to understand someone from another culture. I consider myself a fairly open-minded person, and sometimes I'm culturally clueless. I wrote my dissertation in Bangladesh, and so I have a flavor, for what it means to not get, to decide, or sometimes not even. I mean, it's changed. It's changing now. Not even being told the diagnosis. You're not being told that you have cancer, and do we have a right for transparency? You can say there's a protective element that you don't tell someone. There are some cultures who do that, but in an American culture that is now unheard of. 30 years ago, it was the same thing. And do we have a right to transparency, and who protects whom? So when I have these conversations with someone from a different culture, I just try to learn and try to not be presumptuous. But the basic principle, that we all have needs, and we gotta, somehow satisfy them, hopefully with the support of other people. So if we now translate this to, an Indian version, can we respectfully step into that culture and say, okay, what would it mean to protect someone, trying to protect them by not telling them. Can we protect them in a different way by maybe revealing something? Or what is the desire to reveal it? Do we want to, what's the motivation to reveal it? Do we want to give them agency? So we have to go inward and ask ourselves that question. Why am I about to do what I do, or why am I about to not do something? People always ask for motivations of action, but non-action is motivated, and it often is protective. So, and I'm not advocating for that, but I can see in a cultural context that the motivation is to protect. And if you successfully protect, you can make a case to not reveal. So it's very delicate. And also, we have a palliative care online program to educate people in the space that actually recently, a few years ago, launched in India, because one of our collaborators is a second generation Indian. And so, that we needed local people who cannot tell us, no, you cannot say this. We can't just broadcast it there and expect, an Indian caregiver or an Indian healthcare provider say, oh, that makes sense. So it takes time, it takes respect, it takes curiosity, it takes openness. People don't even get along within the same cultural context. So imagine. Humble, just have to be curious and humble. Very respectful.
It's really hard. Even as an Indian, it's really hard.
Mm-hmm.
Because there's a lot of diversity there as well, right? There's a lot of cultural diversity just in the country. Language diversity. And I think in terms of oncology ecosystem, still relatively young as an ecosystem, right? We still are building the infrastructure. So there's a lot of learnings, and I do think that it's harder in a different way. Whereas here, at least we have the ability to converse. In India, even that, like, there aren't support groups. There aren't communities set up, and we're starting from like the ground up right now, and it's been quite a learning. So, Dr. Kogan, I'm pretty sure we need to have multiple episodes. Going back to how we opened, because I think we've gotten through maybe 30% of what I was hoping we would cover today. Which is
I always have a desire to kind of synthesize what transpired, and I think we talked about the whole stress component, the distress of what it means to move in the cancer space from anywhere, diagnosis to living with illness, and then also this internal, how does my system work, and how does my, in my thinking, my emotions, my body experience, and how do I connect to that system, and how does that system connect to my surroundings? And that's not just other people, it's also the healthcare system. So I think we covered some important points.
I'm going to add maybe 3 more in there. I think one of the frameworks that I think you spoke about at length that I think is actually incredibly valuable is internal stimuli and external stimuli. I think that as a theme kind of cuts across the entire cancer archetypes, and kind of anyone actually grappling with any sort of stressor, but definitely the more existential illness stressors. I think the second sort of theme that we touched on was in the survivor population, right? The grappling with fear, grappling with uncertainty, grappling with trauma, how to live your life while dealing with the daily living all the way to sort of the decade-based living, navigating the ambiguity of data and probabilities. So there was a lot of stuff we covered in the survivorship population. I think we just started talking about the population living with cancer with a specific theme of quantity versus quality. I think your story really resonated, and I'm sure will resonate with a bunch of people, where it's really competing interests between the caregiver and the patient. And it's
And
really
often
complicated.
within the patient.
Within the patient.
It's like every action, can increase quantity or can increase quality, but often not together.
I think your illustration of the cycling negotiation or the constant negotiation really resonated with me, which is it's a constant negotiation. It's not a negotiation that ends and you make a decision, you move on. It's a negotiation that is ongoing, daily for sure, maybe even hourly for some people. And I think the last thing we touched on was cultural expansion. The idea that these principles, while they do translate borders, there are nuances in different cultures, and how we apply these principles might need to be tweaked based on the culture someone's coming from. And if we go into that discussion or conversation with humility and curiosity, at least it sets it up for potential success.
And patience.
And patience. Oh, yeah, I'm horrible. It'll happen tomorrow. I super appreciate it. I really appreciate you coming on this podcast. I have a feeling that a lot of people will resonate with this tremendously. So I am going to wrap up this episode, and I'm going to tee up at some point our second episode that we do together. But for those of you listeners, we briefly mentioned it in the episode today, but Dr. Kogan has written a book that's called, and I don't know if you want to pick up the book and show it to our audience really quickly, but
When Cancer Visits. Yeah, so When Cancer Visits, How to Free Your Mind from the Grip of Distress and Heal Your Jolted Nervous System.
So that's the book she's written. I was very fortunate to have read the manual prior to its publication, and I do think it can be of immense value to a lot of you who are potentially grappling with different aspects of the cancer experience. So I'm personally putting a plug out there just because, it's definitely biased on this one, but I have found it to be really valuable. So I do know it's going to be available online, and we'll link to it in our show notes. And then we will set up time for a second episode.
Thank you very much for inviting me, Samira.
Great. Thank you so much for coming.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.